Now call Scott Weedle with danielstory.org. Welcome to the committee.
Thank you. Thank you, Chairman LaRae, Vice Chair Swearing, and Ranking Member Leland, and members of the House Criminal Justice Committee for permitting me a few minutes today to share my opinion. I believe it's best that I first share my experience with addiction caused by Schedule I and II substances. I've been surrounded by chemical addictions my entire life. I have watched in horror and tragically lost my cousin Dirk, my nephew Andy, my stepson Zach, my only brother Ron, and my firstborn son Daniel, all to opioid addiction. 4 out of the 5 of those started with prescription opioids. The Ohio Alliance for Innovation and Population Health at Ohio University published a study in 2019 about the number of life years lost in Ohio from 2009 till 2018 from this epidemic. The findings were that more than 1 million life years had been lost. My family lost 160. Why did this happen? The opioid epidemic was first recognized by the state of Ohio in 2010. A former Ohio Attorney General has openly shared these 4 facts. The average opioid prescription in 1997 was 7 pills. By the year 2010, the average opioid prescription grew to 65 pills, nearly a 900% increase. 4 out of 5 heroin users started with prescription opioids. The pain med problem is fueling the heroin epidemic, end quotes. Currently, the state of Ohio's prescription drug monitoring program called OARS contains a yearly legislative report. The report states that the average opioid prescription is currently 60 pills. Please note that a prescription opioid is a Schedule II substance, which is the most dangerous substance permitted to be sold. It carries this definition: substances with high potential for abuse, with use, potentially leading to severe psychological and physical dependence. Please also note that the primary medical brain disease of addiction is considered in the medical journals as chronic and progressive, if left untreated, is often fatal. When I lost my oldest son Daniel to this epidemic, I had not yet made the strong connection between prescription opioids and heroin. Folks, I learned too late. They are nearly one and the same as how do they affect the brain once ingested. I wish someone would have educated me 2 decades ago about what addiction is and is not. I carry a lot of remorse now, knowing I have made some very bad mistakes as a parent, as a family member, towards those that battle this disease in real time in front of me. I wished I had understood the simple medical conclusion about addiction. For a medical condition to be elevated or classified as a disease, it must pass 3 criteria. For example, fibromyalgia is not classified as a medical disease, but addiction is classified as a medical disease in the medical journals. This is not an opinion-based statement. It's a proven scientific fact, and I hope that grabbed your curiosity. The 3 criteria required for a medical condition to be classified or elevated to a medical disease is, number 1, it must be detrimental to your health. Addiction is clearly that. There must be a specific set of signs and symptoms. With addictions, there is. And number 3, the most important, there must be a medical test that, when given, is always abnormal. – With addictions to chemicals, there is clearly the medical test. It's a simple brain scan. Someone in the throes of addiction, weeks sober, will show substantial reduced brain activity in its frontal lobes area compared to someone not battling addiction. The frontal lobes controls your cognitive decision-making processes. Most people look at addiction as simply a daily choice by an individual. That is not the case once the disease stage begins. Addiction to a Schedule 1 or 2 substance is chronic and progressive like cancer. An example to this statement, let's say all members of this committee started smoking at 18 years old. A number of you will develop lung cancer. A number of you will not. The reason for this is genetics. You have very little, if any, control who develops cancer and who does not. The same basic theory works for who develops addictions and who does not. Please note there are 2 other potential factors involved in developing addiction besides genetics. Number 2 is the undertreated or untreated mental health disorders such as depression, anxiety, ADHD, panic disorder, etc. Number 3 is the overexposure to Schedule 1 or 2 substances. These are the 3 factors that are the significant causes to how primary medical brain disease called addiction develops. I do understand this committee as the Criminal Justice Committee. Because of that, I suspect it's easy to focus solely on deterrence using criminal punishment. I can only suggest that one should examine the past criminal enhancements over each of the past General Assemblies to gauge how effective they have been or not have been. The statistics do not support past criminal enhancements have decreased the death statistics and carnage caused by this epidemic. I hope that the legislators' motives here are not driven by the desire to use these types of efforts as bullet points for political campaigns. I do understand everyone here has made up their mind on the bill. That's okay too, no harm done. I'm here to plead with this committee and the entire General Assembly legislative members to, in the future, focus equal times towards improving the educational effort to all of society in order to reduce the stigma of this man-made epidemic and towards improving the dysfunctional treatment system we have. Instead of drafting legislation pushed by folks that take a paycheck from some of the systems I call dysfunctional, reach out and talk to some citizens that have close family members with experiences inside of Ohio OBOT treatment systems and some of the dysfunctions inside these systems. There are many things that could be done towards relapse reduction and to improve treatment issues. Enhanced penalties will not cause any measurable positive gains to anyone on both sides of this epidemic. We have done this since the Reagan days, and we are losing the battle each year. One of the main keys to reducing stigma of addiction and improving treatment options to addiction is with education of what addiction is and isn't to everyone. I hope and pray all legislators will make that a priority in the near future. Thank you for your time today, as well as your future consideration to my plea.
Thank you for your testimony. Are there any questions for the witness? Representative Schmidt.
Thank you, Mr. Chairman, and thank you for your compelling testimony. I read a book a while back called Dreamland. It's about the opioid issue and the tar heroin issue from a very small village in Mexico. But the centerpiece of the opioid addiction is Portsmouth, Ohio. Portsmouth, Ohio is a very small town. I wouldn't call it urban at all. It's 2 streets and a college and a couple of restaurants. But it is the center point for opioid addiction, not only in Ohio, but in the United States. Today, it has numerous drug treatment centers throughout the town, and yet it hasn't changed the dynamics of the opioid/tar heroin addiction that is in Ohio. I'm at a quandary as to what we can do to help alleviate this. I have an issue with a step-nephew in my own family. I volunteer at City Gospel, and I don't know what the right answers are to address this issue. If you can help guide me, I'd really appreciate it.
Thank you. For years, I tried to punish and shame my loved ones into sobriety, and it doesn't work. All they're wanting is validation of their disease and love and support. As to the treatment systems, there are some problem issues there. And basically, there's three types of treatment systems. The way I see things, one is residential rehab. Residential rehab is when you go out of state. You go for 30 or 60 or 90 days. You become completely removed from your environment. Your phone's gone, your internet connection's gone, your family's gone, your bad influencers are gone, and they teach you a different way to live. And most people thrive in that environment. Problem is two things, is it's about $1,000 a day, so not many people can afford it. And number two is when that person comes back into the old environment that they left, is typically crippling to them. So the residential rehabs typically don't use medication-assisted treatments, medicines, but they are a little bit more effective, but the majority of people can't afford to go there. The other two treatment options is OTPs and OBOTs. OTPs, opiate treatment providers. OTPs are kind of the gold standard. They are federally accredited facilities. There's only a handful of them in each state. They're typically only around the large urban areas of Columbus, Cincinnati, and Cleveland. So it knocks out 90% of the population to be able to have access to an OTP. OTPs are staffed with 10 to 20 people, college graduated people, and they offer a higher standard of care. The other level of care that 95% of Ohioans are forced into are OBOTs, Ohio-based opiate treatment centers. To become an OBOT facility, all a dermatologist needs to do to open up an addiction clinic and put his name in the yellow pages is to take an 8-hour online course. It's not a pass-fail. It's called a DATA 2000 waiver. And that dermatologist tomorrow can be an addiction specialist and open his doors up and call himself an OBOT clinic. And the majority of the drug trafficking or drug diversion that happens in OBOT parking lots comes from the medications that are handed out inside the OBOT clinics. It doesn't come from the ice cream truck drug dealer pulling up the street trying to find a new customer. What is handed out in OBOT clinics is MATs, medication-assisted treatments. The largest medication is buprenorphine, also called Suboxone brand name. It's a good medication. It works. It's kind of like a nicotine patch. You take one a day and it gives you a controlled dose of opioids, which is better than the street version of you never know what you're getting. But that medication has a delivery system problem in that the folks that are inside the OBOT clinics taking the IOP classes, which is the biggest dysfunctional problem, half of them are there because the judge or the criminal justice system forced them there and they don't want to be there. The other half might be from the parents forcing them there, and the other 1/3 is because they want to be there. And it's these 1/3 of people that want to be there, like my son Daniel was, that is always corrupted in the parking lot on the 10-minute smoke break every hour when we go hang out with the folks that were forced there by the criminal justice system. So to try to wind this up, OBOTs and IOPs is a big problem that needs a lot of attention. The last week Daniel was with me. He told me, "Dad, I would go back to the OBOT clinic and get my Suboxone." But he says, "You know what's going to happen when I start hanging around them people." So we chose not to.
Follow-up, sir.
Follow.
The book you have, Little Boy Lost, Who was it written by? I'd like to read it.
I have copies here with me. This is kind of my memoir. It's Daniel's story. I advocated in this building for a year in the 132nd General Assembly, walked away with Daniel's Law. Nothing like I wanted to when I walked into this building, but I did walk out with something. I've had numerous doctors and medical providers tell me they've learned more about addiction inside this book than they learned in their education for becoming a doctor.
Representative White.
Chair LaRae, Mr. Weedle, I just want to acknowledge all you've been through and the generous way you have attempted to impact not only our local Dayton region, but the state. And so I just want to acknowledge and thank you for taking the time today. It's very important that people with lived experience come and share. So I want to thank you for that.
Thank you.
Representative Golonsky.
Thank you to the chair, and thank you so much for your testimony and for being brave and willing to share with us. It's been very helpful. I would like to focus on the parts of your testimony that talked about, I believe it was either 1996 or 97, the average drug or opioid prescription being in the single digits, but then now here we are at 60 some odd pills. There are right now people listening to my question and hoping I'm not suggesting what I'm suggesting, but why in the world would we keep that number as high as it is when it doesn't need to be?
That was my direction with Daniel's Law when I came to the Capitol in 2017, was prescription opioid reform. And basically the medical associations shut me down.
Mm-hmm.
It's why Purdue Pharma is writing checks with, I don't remember how many zeros are on the bottom of that check. But what happened in that period was that opioids were never prescribed in the primary care setting. And in the late 90s, a pharmaceutical company reformulated these opioids and called them extended release. And they psychobabbled the system to believing that they was non-addictive because they was extended release. The system bought it. They presented false information and received approval to promote this as non-addictive. And this pharmaceutical company decided to hire an army of pharmaceutical sales reps to target primary care providers to prescribe opioids for long-term chronic pain. And that's where the snowball started down the hill, is that had never been done inside the primary care system, nor had it ever been done for long-term chronic pain. Now everybody expects it. It's the happy pill. It's medical consumerism. When you go to a doctor with a cold and you walk away without a prescription, you get mad. You need to give me an antibiotic. An antibiotic's not going to help the cold, but he's going to write you one anyway. It's the medical consumerism. I have a sore back or I have a sore hip. They often feel pressured into giving you something for your complaint. And now that the only effort that's been happening legislatively, and the governor came out a rule to stomp out Daniel's Law in 2017, that he was going to put a lid on opioid prescribing, but the only thing he put a lid on was the acute pain dispensing. Acute pain is short-term pain lasting less than 7 days. We're only going to allow 3 or 5 pills, but we're not going to talk about the chronic pain. So also in that rule that's in effect today, in the fine print in the bottom, if you get your magnifying glass out, it says, all doctors have the clinical judgment to override this. So there's nothing ever enforced, there's nothing ever followed through. It's a lot of smoke and mirrors about putting the genie back in the bottle. And that's part of the problem. You can't take opioids away from people that are already addicted legally to prescription opioids. You cannot go down that path, and I respect that. But we can grandfather that group of patients and leave them unharmed to continue to get the legal pill that they're prescribed, so we do no harm to them, but we can certainly protect Johnny and Jane from becoming these folks by not allowing prescription opioids to be prescribed for chronic pain inside the primary care system. And that was the root of Daniel's Law in 2017. And I was told that this number that the OR system preaches would go down drastically after the past governor put this new rule on. And I just shared with you today, it's still at 60. It didn't work.
Representative Plummer.
Thanks, Chair. Thanks for coming in. It's great to see you again. I've been to your house a few times, as you know, and he's committed his life to this, you guys, and he's frustrated, as many as us are, because this is a slow-moving ship, but your knowledge is really appreciated. Myself and Representative Young are working on this number of pills being dispensed issue as we speak right now, so hopefully helps on the way. I was encouraged yesterday by the governor's State of the State speech when we're talking about dealing with people with mental illness. A lot of this is, co-diagnosed mental illness and substance abuse. So he promised help's on the way also. So hang in there. We appreciate your strength and courage and your dedication to this, but we haven't forgot about you.
Thank you very much. I did hear that part that the governor talked about yesterday, and mental health is commingled into addiction. But I would just like to briefly add that often when people talk about mental illness, it's the mental illness people that need help. It's not to the level of we need psychiatric beds for these mentally ill people to keep them from getting addicted. It's nowhere near that. It's a third of the people in this room is battling with some type of depression. They're on some type of antidepressant, and they have some type of anxiety disorder. And for a young person that's never knew life other than being depressed and having anxiety, and when they go to the dentist or the doctor and discover an opioid pill for a sprained ankle or sprained knee from soccer practice, and they take this opioid pill, and all of a sudden their panic disorder is gone. All of a sudden their anxiety is gone. That fixed their underlying untreated mental health disorder. It's not schizophrenia. It's not the homeless person on the street. The mental health issue is in our families, and that's what's not being treated. We don't need psychiatric beds for that. We need mental health help inside the primary care system. Get the opioids out and get the mental health in. Thank you.
Thank you for your testimony.